Okay. So hi everyone, welcome to Gram Round, and today I'm gonna talk about two cases actually, and I call this presentation the silent divide. And I have no financial disclosures, so I'm just taking this away. Okay, so we have this patient present to the Hospital de la Familia Clinic. She's a Mexican female, 53 years old, who complained of ocular pain in the right eye. So the patient, as you can see, we did really had a very blurry vision of the fundus, and basically he had light perception in the right eye and counting fingers in the left eye, with an increase in the intraocular pressure in both eyes. And I'm going to go through the medical history right now. So patient only referred a headache, but in his past medical history, he was diabetic for 20 years. And also, let me just disconnect this, I'm sorry. And also he was hypertensive and had chronic kidney failure. 3 months ago, he had overcome two surgeries, one a phaco and a bulb, and he had laser capsulotomy all in the right eye. Yes. He denied any other diagnosed. So basically, we're gonna go very straightforward. We have a PDR and a neovascular glaucoma in both eyes. So we started hypertensive drops, anti-VEGF treatment, PRP, metabolic control, and also sent for a cataract surgery in the left eye. And this is a 2 months follow-up. In the right eye, we could have a better view, and the patient had a tractional retinal detachment, which was very bad prognosis. And in the left eye, vision improved. So we have a 20/100, and intraocular pressure was starting to lower down. We still didn't have the PRP. Patient wasn't able to get done or performed or come to it. So basically, he had been treated with only the hypertensive drugs and the anti-VEGF drug. 3 months follow-up, the patient overwent the PRP. And 5 days after the PRP, the patient consults again to the clinic because of a decrease of visual acuity of 4 days. So he thought like the laser provoked the loss of vision. And he was counting fingers, and the ocular pressure was 20. He stopped his hypotensive drugs. And as you can see, there's a whitish area in the macula. And of course, this is a very severe diabetic retinopathy, proliferative, and you can see some marks in the retina of the laser. And here, so we did an OCT also, and as you can see, we have a very atrophic area of the fovea. We still have a very nice preservation of the external layers of the retina, but as you can see, there's a hyper-reflective area in that represent the whitish area, and in the other area that was more whitish area or a bigger area, we can see the hyperreflectivity of the internal retinal layers. So we are here diagnosing either a branch retinal arterial obstruction or thinking also in a cilioretinal obstruction. And of course, this patient needed more studies that we weren't able to give because we don't have an FA, but we just got it actually. So it's just waiting for an unboxing in Nuevo Progreso. So that's something that's just coming soon, and it's going to be available for us in Nuevo Progreso. So I wanted to talk to you about retinal arterial obstructions because it's something very important to remember that is an emergency condition, and we should actually assess this in a very proper way and in a very short time frame. So basically, we can divide this in optical and in ophthalmic arterial occlusions, central retinal arterial occlusion, branch retinal arterial occlusion, and the ciliary retinal occlusion. Usually, the ones that are actually more common is the central retinal arterial occlusion, presenting in 1 and 2 cases per 1,000 person annually. And that's the same for the branch retinal arterial occlusions, and the other two are much less common. So the risk factors are systemic, so the hypertension, the diabetic condition, the hyperlipidemia, and other cardiovascular disease. And we could have also ocular conditions that are risk factors like glaucoma and optic distortions. So you can see a lot of things that our patient has here. And in the clinical presentation, we should be aware of the symptoms, which is usually a sudden painless vision loss or either a visual field defect. And the signs is this characteristic of the widening of the retina, the famous, of course, cherry red spot, and the segmental retinal widened if you have like a branch obstruction. The diagnosis evaluation will be actually divided in an ophthalmic evaluation and a systemic evaluation. So we will, of course, we all know that we do a visual assessment, the fundoscopy, the FA if it's available, and the OCT. And now systemic evaluation is very, very important, and we should refer the patient immediately. So even if we didn't have the FA, it was more important to refer the patient. If, of course, this patient was a little late because it's been 5 days from the event, 4 days from the event, and he should be evaluated. He had for cerebral imaging, cardiovascular, carotics, laboratory tests, searching for hypercoagulable states and autoimmune diseases depending on the age and risk factors. So basically, this condition, it's a stroke. And this is very important because the retina is actually an extension of the brain. So it's classified as a brain tissue. And this is the same as having actually a stroke, a cerebral stroke, if you call it like that in USA. We call it a little different here. But so it should be assessed the same way. So actually, we're gonna divide our strategies if it's acute, and then a secondary prevention, because you could have a second event and not necessarily in the eye. So you need to prevent a second one. So the time frame usually there's a diverse kind of opinions, but at the end everything comes down to 24 hours. And there are some studies about in mice that said that retina tissue can only survive 90 minutes without the supplies. And there are some discussions about maybe in humans are 6, but it's very variable because different conditions. And so basically at the end, most of the interventions should be done within the time frame of 24 hours. So basically, we as ophthalmologists, we can start an ocular massage, an anterior chamber paracentesis, and hyperbaric oxygen therapy. There are also like some other kind of as a surgery. There are some in Asia are performing, like doing a vitrectomy and kind of like trying to take out this clot that it's presenting or obstructed. And I've seen very impressive video of it, but I haven't seen that available in America. And so the secondary prevention will actually depends of the systemic evaluation and, of course, modification of the risk factors of the patient. So this is the other case, and I wanted to present this because this is a case that I actually managed these last days here in the city. So ironically, it's also Mexican, This is a female, 30-year-old, and she presented with a vision loss in her left eye. So she was to refer to us very, very fast, within 20 hours of presentation. She had a better luck, of course, because as you can see, the fovea is intact, but she is like her visual kind of exigencias, I don't know how to say that, are very, very precise because she's a dentist. So she was very worried. We, of course, did the cardiovascular evaluation, and the patient, actually, we found a permeable foramen ovale, which I investigate after that, which can actually provoke some clots and send them to the brain or retina, as we can see it. And also, there's like 30% of the population that is presented, but you have to have like 2 cerebral events, occlusions, to actually consider to close it. So that was very interesting for me. So the thing, in this hospital in the city, we have something that I'm usually not like that common, that we don't have available any other place, which is this chamber for the hyperbaric oxygen therapy. So she's been undertaking like 6 sessions by now, and or I think 6, yeah, like an hour ago she got her 7th session, and she's actually been referring that the scotoma that she started with is starting to become, instead of very, very black, which was for her, now it's grayish. So I think that's an impressive result. So those are like the 2 worlds we present in Guatemala, which is very ironically, because in 6 hours in a car, you can see how difficult for someone is to get access, to get care, appropriate care, or referral to the appropriate evaluations. So that was actually very sad for me to think about, but it was very interesting also to get to manage both cases in a different context. And so, of course, we want to talk about the prognosis. So if we manage the time frame, I've seen impressive results in papers, but generally, if you have a central retina obstruction, you basically have a poor prognosis. And now if you have a branch retinal obstructions, well, it's going to depend the location and the extent of the occlusion. But something I also learned a lot from this, because in some contexts, like, patients don't care about much of their periphery vision, but of course people like all the ones that are present are gonna care about their visual acuities and their and like the periphery, because we depend, our job depends on that. So at the end, I just wanted to highlight, like, we should detect these conditions very early and prompt for a manager that it's appropriate, and referral, and try to like give some follow-up to the patient. I know, like, sometimes in Nuevo Progreso is difficult because we have a very high volume, and sometimes we don't have like available dates for patient, or to see them in closer dates. So that's something that's painful for, I think, everyone, but something that we're trying to change. And this is, I mean, the difference of treatment, it's just so impressive, 6 hours away. And what at the end, all these patients should be sent to a stroke center. And we should focus also on patient education, symptom awareness, and like lifestyle modifications. And these are, well, basically my refers. So I'm just gonna go back here and see if someone wants to comment.
First of all, Isa, thank you for the cases and the class on arterial obstruction, because sometimes we don't get to see that often, and it's always a good refresher. Um, did you work with a cardiologist to diagnose the Mexican dentist?
Yes, yes. Actually, I'm working right now. Actually, because we agreed to do 6 sessions with the patient because she is very exigente with her vision. So
Yeah.
basically, we're still working, and we still have some studies that we haven't get the results, like the la tomografía angiocoronaria,
Yeah.
which I'm not used to translate. So sorry about the bad English. And but for me, it was really interesting to because we usually only refer, and sometimes in Guatemala, for example, when I was a fellow, I have never actually thought about referring to Centro Médico, that which they have the chamber. So I think that's something that we should promote because I mean, if I had an obstruction, of course, I wanted all things are available.
Yeah. I agree.
I think the thing that
go
I'm
ahead.
sorry, go
no,
ahead.
No, go ahead, Eric. You first.
I think the thing that we've been seeing in the literature is different centers talking about having a stroke-like TPA protocol for these presentations, and I'm sure some of you other folks have seen those popping up. I'm wondering if any of you have personal experience, because as Isa said, it's basically a stroke.
That's what we do here at the University of Colorado. It becomes a stroke protocol, basically, that the patient goes into. But the confusing part is when ophthalmology is there with the stroke team, and we're trying to do certain things that conflict with what the stroke team wants to do. And then if you read the literature about what to do for a CRAO, a lot of the treatments conflict. So we're talking about paracentesis and we're talking about ocular massage. And you have two trainees who are arguing over who's going to massage while the paracentesis is happening. So you have to be really careful with how to approach this. There's talk about high concentration oxygen, but then there's also talk about breathing into a bag to increase CO2 to vasodilate. So it's what we typically do is we do a paracentesis, and the way that we do it is, I don't know if it's different than what most people do, but we take a 30 gauge needle, we put it on a TB syringe, we take the plunger out, and we put the needle tangentially in, and that actually equilibrates at a pressure of around 10 or so. And then we have the patient, if there's a stroke protocol, if it's within a short period of time, they go into the stroke protocol after that. But again, there are a lot of conflicting, and I would imagine in Nuevo Progreso, where you are, that there isn't a stroke protocol that happens when these patients go in.
No, I mean they usually come very late, so the time frame to treat them it's very very lost because this patient came 4 days after.
Yeah.
And I mean, but at the end, we all then send them. For example, this patient is Mexican. He cannot stay in a hospital, local hospital. Yeah. So I actually talked to him, explained to him, and sent him to his country, which was 4 hours away for him, and to get the immediate care and investigations that he should. I mean, but we were already late. Mm-hmm.
So you said 90 minutes. When would you initiate a stroke protocol and if you had the access and had TPA and had
it's just immediately. I mean,
yeah.
The studies, they're not 90 minutes with the mice studies. It's like those are animal studies. We haven't really looked at how a retina in a human can support a no perfusion. I mean, there are some. I mean, in Ryan, for example, talks about how you can measure the pressure in the eye, and it will take an hour to like be okay. after an hour, you will get some damage. But then there are some discussion, because I read a lot about that in these last days, and that you should actually be thinking in 6 hours to be as fast as to like decompress, do massage, and do the hyperbaric chamber if you have it. And well, I will guess that in Asia they are doing this cannulation surgery, which I thought it was very impressive. I mean, but also very risky. And then, but the stroke should start as soon as immediately, because you have to prevent a second event, which could be cerebral.
So if it's 24 hours after the CRAO, or would you still initiate a protocol or beyond?
Well, I think we should always try it, because the patient wants you to. And I've seen some patients, like, for example, I managed one when I was a fellow in Robles, which came like 2 days after. And we did the massage and the compression, and that's as far as we went there. And he went from like counting fingers to 200, which I thought it was something. So I mean, for a good prognosis, we should be acting 6 hours. In 6 hours of the loss of vision, and 24 hours to most of the authors. But then after that, I always think that we should do it because of the patient.
Would this is not scientific, but if you'd lost vision 48 hours before, would you want to have all those things on your eye done? If it's 40,
I would. I mean,
if
it would just decrease my scotoma to not make it that black, like this happening with this patient, I will take that definitely, because it's gonna be easier for my brain after recovery to manage, like, compensate for the visual kind of when you kind of like do a PRP and then your brain makes sense of it. If you have an artery obstruction, like it's just in an area like the branch. If you have a central, I mean, of course, it's better to have a 2200 than a count fingers. So I will always go for it.
Lisa, in your studies, in the absence of these hyperbolic chambers and the TPA and all this advanced stuff, if you're in a clinic, was the research showing, is there any use of giving somebody an aspirin, like a 325 aspirin, when you first encountered them?
Yeah.
And then would anybody in the audience do that in the absence of some of these high-tech things?
I will consider it, but for me, and in my experience here in Guatemala, if you treat the patient, or if you give them like, you have to do this, but I'm gonna give you this medicine in the meantime, they won't go to the referral. I mean, if you partially give a treatment, it's very sad. So I have found in my population that I just have to be very straightforward. Like, you have to go to the hospital right now, because at the end, life is at risk for them.
Maybe it'd be more gauged to the United States doctors. Anybody in the audience, would you, in your office, that happened tomorrow, would you give him an aspirin, Andy, or Eric?
Before they get to answer, Isa, what are the main studies that you're reciting again?
Well, something I will that you could go for a great guideline is the preferred practice parents for arterial obstructions. And then I read tons of articles, and actually there's a review for hyperbaric oxygen therapy, which is very, very extensive, very impressive. I can send it to you, because we got the protocol out of that. It was the first time we managed that here in the city, and we had that available. So we had to talk with the like, we were like 4 doctors: the doctor that consulted, the cardiovascular, the doctor that's like in charge of the hyperbaric chamber. And at the end, we ended up using like raising the atmospheric pressure at 2.7, which you can do even 2.9. But in our population, we have to start like raising it like from 1.5. But most studies that are made outside, of course, Guatemala, they start with 2. But our patients are used to that.
Hi, my name is Mark Wheeland. I'm a retina specialist. I'm down here at New Haven Progresso right now. And I was just going to comment that I think really in the last 2 to 3 years, this has really taken on sort of the immediacy of the stroke protocol. And I think you have to sort of prioritize in your own mind, what's most important. Is it important to do a rapid AC paracentesis and get them to the ER, send them directly to the ER and meet them there? I think most of us that have tried AC paracentesis and massage have had pretty dismal results over the years. And so I think that the thinking now is really much more that this really is stroke protocol. And if you want to hustle over to the ER and do an AC paracentesis and massage the eye, that's great. But the emphasis is now really more on stroke protocol.
If I could just chime in on something, because we have a lot of clinicians in a variety of different stages of training and understanding. But when we're talking about stroke protocol, we're really talking about 2 things. One is the therapeutics, and that I think is what's exciting and what we're talking about, the idea of using hyperbaric oxygen or TPA, which is more of a new thing. But the other thing that we're talking about is the diagnostics. Why did this person get a thrombus in their central or branch artery? And that's, I think, crucial, like Isa said, to preventing them from having a second sight. So I just wanted to clarify to make sure everybody was on the same page. We're trying to find out the why, but also try to fix.
Yeah, I'm looking at the preferred practice patterns that for 2024. And it does say after the acute phase. So I'm wondering what is the acute phase? This is after the acute phase. There's no proven treatment to reverse the vision loss. Currently, there is insufficient evidence to support intra-arterial or intravenous antifibrinolytic therapy for CRAO. So is that not the accurate? Is that inaccurate now? It sounds like.
I think that's accurate. Yeah.
Is that still accurate?
Yeah.
That's right. So, as I hear your question, Rupert, I always worry about, asking a panel of people what they wanted, what they would do, because I think it risks becoming a little less scientific. And yeah, so I just I don't think I'd want I think in that first hour I'd want to have my eye tapped, but if it's 2 days later, I'm not sure I'm going to drive down to a hyperbaric chamber and even if it was covered by insurance, I don't think I don't know. I say it doesn't look like we have a science for it.
It's also like it could make you beautiful and younger too. I mean, I'll try it.
It really is a timing issue, isn't it? And so it's so rare for us to see an acute artery occlusion within that 90-minute period that it sort of begs the question, how effective are we at really treating that? Should they go directly to the ER and you meet them over there, do the big workup for the etiology? I sort of feel like that's where things are going.
So I have a question. In our hospital, the goal is the second they walk into the emergency room, within 45 minutes, they can give the TPA or treat. Really, in those 45 minutes, what they're doing is they're getting labs and imaging to rule out contraindications for TPA. If you know it's a central retinal artery occlusion, couldn't you just do the TPA? Is my first question. Then, are there studies that show that TPA actually helps patients that have central retinal artery occlusion?
Sorry, I think I didn't hear you because you were cutting. Can you say it? Can you say it again? You were asking about
so
TPA.
once somebody gets into the emergency. Yeah, so once someone gets into the emergency room, really the whole delay is because they're trying to rule out any contraindications to use the TPA. And with labs and imaging, if we know it's a central retinal artery occlusion, they don't, do they really need imaging? Or can they just get the labs and then treat with TPA, and would TPA help someone's central retinal artery occlusion? Are there any studies that show that?
I really don't remember reading about that specific question. I can tell you that the cardiologist was like very ready to give anti-fibrotic agents as soon as the patient got the first studies, the first labs, which for the patient managed in the city. So he started it very fast, and I, of course, I was like wondering, because this was my first encounter with such a good, complete and advanced kind of attention for a patient and fast. But he really was like, no, you can do the decompression, you can do this, I'm gonna start it. So I felt him, and like I kind of relay his cardiovascular experience for that. So, but I mean, I could look for it too. Kenny, you have a question?
have a question.
Oh yeah. So one thing I want to mention, at least in my training, and I'm curious for other people, was that when you saw a central retinal artery occlusion, sure, a lot of times, it ends up being a stroke. But one thing we were always taught to screen and check for is giant cell arteritis. So checking the ESR, CRP, review of systems for temporal arteritis. I'm just curious, is that, I know in Guatemala, I mean, is that a diagnosis that is seen in Guatemala? Because, then the treatment is very different, right? In terms of thrombolytics versus steroids and protecting the fellow eye. So I'm just curious about, the role of evaluating giant cell in the setting of central retinal artery occlusion.
I think that's a good question. You should be thinking in that diagnosis in patients over 50, if I'm not wrong. And also, we did studies with the young patient. We did some autoimmune studies, but they actually take more time. So those are something that you are gonna be a delay in the treatment. So at the end, the stroke protocol is they started because they are assuming it's usually more cardiovascular, but because it's more common. I mean, and by the question that if we have seen it, I have seen one diagnosis in Guatemala of giant cell arteritis.
Thank you.
I want to throw out a question to some of you really astute clinicians here. How many of you have identified the embolus responsible for the occlusion, either wedged in a branch or, maybe it was in the central artery, but it's worked its way down to one of the tributaries or one of the bifurcations? And I'm curious because we read about how people can discern between a cholesterol fragment and a fibrin fragment. And is this, I mean, maybe I've seen that here and there, but, am I just not a very good doctor to pick up on these things, or are you guys picking up on these things and I'm not?
Well, that's the Holland horse black, which that you mentioned. That's very, very beautiful to see. I've seen some. I haven't seen much cases, but I've probably seen it in two. But little to said that 70% of cases can present with it. And I don't know if anyone else can want to comment also.
My experience is that the Holland horse plaque has that classic sort of refractile appearance, and the fibrin, the clot, you see this longer appearing whitish, non-refractile element. Not always, perfect, but the Holland horse does have a pretty definite appearance.
But at the end of the day, the clinical diagnostic workup, you're going to do the same thing. You're going to still check the carotids, do an echo. You're going to do the same exact stuff.
Yeah.
Do a brain image also is very important.
Yeah, Eric, yeah, I don't think you're a bad physician. So I've I've never seen an embolus in any patient that has come in with a CRAO in 20 years of practice. And we've looked. I think part of the issue is there are degrees of CRAO, and the studies don't actually distinguish between a complete versus a partial. And if it is a partial, then I want everything done because you might be able to reverse it. If it's complete, your cells are already dead probably within a half hour or so. So it's just it's not a great scientific discussion, as Andy was kind of pointing to, because we don't have great data to help guide us in what to do. With TPA, there was a great question about, can we just go straight to TPA? I can tell you in our emergency room, there's no chance that they're going to do that because of the threat of legal action if something happens with bleeding, which can happen a significant amount as far as intracranial bleeding, GI bleeding. So they actually go through the whole panel of testing before they start TPA, which also has not been shown to have great benefit for a CRAO. So it's a very frustrating problem. All of the surgeries that I've seen that Isa pointed to, they all look like somebody's jumping off the cliff. They look too dangerous to me. I don't think it's anything that I would want done in my own eye. So this is an unmet need in ophthalmology where somebody can come up with a better algorithm and potentially a better treatment down the road. Fortunately, I don't see too many CRAOs. I can't actually, in the past couple of years, I don't think I've seen one walk into our clinic. So I don't know how common it is with your clinics.
Well, I've seen 2 this year. These 2.
But also, just at it, intriguing to me is we have pretty high volume, just more of a general practice anterior segment. We see CRAOs come in. We always send them down to Dr. Jung and Dr. Rafaga to take care of. And one or two in particular, it's always stunned me how they come in with really terrible looking eyes, and over 20 years, like one or two that had pretty near complete recovery of vision despite no real intervention, which I just think that just goes to show that we're a lot more plasticity than we understand. So that suggests that there would be some way to reverse that acute event if we could unlock the tools that the body sometimes naturally uses. So I hope I don't get one of those.
Well, thank you. Thank you for all the comments.
Yeah, great case. Cases, great cases. Yeah.
Yeah.
Thank you, Isa.
Thank you. Great case.
That's great. Great event.
Thank you.
All right, everybody.
Be safe down there.
Yeah, have
Thanks
a good
a lot.
evening. Yeah,
Thanks.
bye-bye.
Bye-bye.
Great case, great case.